Good evening, everybody, and welcome to our Reducing Alcohol-Related Harm in General Practice webinar. This event is in partnership with the School of Primary and Allied Healthcare, Monash University. My name is Helene. I'm the Workforce Development Officer at Westvic PHN, and I will be a facilitator for this evening. Alongside me is Jade, who also is in the work development team here at Westvic. I'd like to begin by acknowledging the traditional owners and custodians of the unceded lands and waterways. I'm meeting on Wadawurrung country tonight. We recognise their diversity, resilience and the ongoing place that First Peoples hold in our community. We pay our respects to elders, both past and present, and commit to working together in the spirit of mutual understanding, respect and reconciliation. We support self-determination for First Nations peoples and organisations. Just a little bit of housekeeping. You can view the majority of our webinar recordings on our PHN Learn YouTube channel. It's on the screen at the moment. We will put the link, so that's it. Please see our upcoming events on the screen. You can register for these on our website, and we'll put the link in the chat for you also. Please make note of our Westvic PHN health pathways relating to this topic, and that's on the screen at the moment. If you have entered the webinar not displaying your accurate first and last name, could you just please type your full name into the chat box? Only the admin will see this, and this is to ensure that you get your certificate of attendance. For this evening webinar, all participants will remain on mute. If you have questions, just type them in the question and answer box and I will ask them on your behalf to the presenter during the question and answer time and also throughout the evening. It'll all be anonymous, so just put them in there. Your feedback is important, so if you could take the time to complete the event survey after the webinar, and there'll also be a link in the chat to complete this. Our presenters for this evening are Associate Professor Elizabeth Sturgiss, Dr. GP Associate Professor of Research in the School of Primary and Allied Healthcare at Monash University and Visiting Fellow at the Australian National University, whose research focuses on chronic and complex diseases among priority populations. We also have Dr. Hester Wilson, a GP and a registered fellow of the Royal Australian College of General Practitioner, and Dr. Mark Davies, GP, Bowen Health Drug and Alcohol Services, and they'll be introduced throughout the webinar. I'll just hand straight over to Liz now, and she will commence the webinar. Thanks, Liz.
Thanks, Helene. Thanks for that really warm welcome and lovely to be with everyone here today. I don't know about everyone. I had a long day in clinic today, so it's nice to join with colleagues and have a chat about something that's really important in all of our communities. So we've got some slides to share, so I'll just bring those up. Tonight, the work that we're presenting is, Hester and Mark and I will be with you through the evening. The research that we're presenting was funded by the Victorian Health Promotion Foundation, otherwise known as Vic Health, and we just wanted to acknowledge them as our funders. So tonight we're really looking at alcohol brief interventions in general practice, a really important and effective part of the work that we all do, and hopefully spark a bit of interest in your own mind, because sometimes it can get a little bit I don't know about you, but stuck in a rut with talking about alcohol with patients. So some new ideas, different ways of talking with people. Hester, Mark and I are really happy to take your questions throughout. So if we're saying something that you'd like more information on, we're saying something that sounds completely off what you would normally do, or you have an idea yourself, please pop those in the chat. We're really happy to take those as we go along. And as Helene said, there'll be another Q&A opportunity at the end as well. So to start, just to give us all a little bit of context, so this is the Australian scene. Often when we think about drugs in Australia, we forget about alcohol, but it's actually the one that causes one of the most harm across the community. Some of this data is a little bit old now from the AIHW, but if you think about people who are actually seeking care for drug and alcohol concerns, alcohol is actually 35% of the people's most common drug of concern. So it's one that causes harm sort of at that risky level at home, but also through to people who are needing hospital and tertiary care. So I keep forgetting, Hester, but I think it was 2020 when NHMRC updated their guidelines for alcohol. 2020 feels like yesterday, but also such a long time away. But really, the new NHMRC guidelines are talking about drinking less alcohol to reduce harm altogether. And for some people, not drinking at all. And as GPs, we know people's chronic health conditions, we know what's going on for them more generally. So I think we can provide that more personalised advice about people where it is less risky to drink less. But in 2020, they did kind of change their guidelines quite a bit. We might be used to them by now, but no more than 10 standard drinks across a week. And then on any one occasion, no more than 4 standard drinks. And then really advice not to drink alcohol during pregnancy. Some of these images that I'm showing today are from the research that we did with general practice, and they're available freely online. At the end, there'll be a QR code you can access, and you can very welcome to use these in your clinic as well. The little outlines there of what is a standard drink can be helpful for sort of talking with patients about how much they're actually drinking. Hester, do you tend to use those kind of pictures in your work, or?
Yeah, I find them really useful. So for me, it's, the 100 mils of wine, which is actually a tiny bit in the wine glass. I don't know about anybody else, but I've got glasses at home that take 600 mils. So I could fill it to the top and say I only have one, when in fact I'm having 6 standard. The 30 mils of spirits. Beer can be a bit interesting because you've got your full strength, your mid strength, your low beers, the zero beers that actually the ones that are sold in supermarkets, many of them still have some alcohol. So that's a bit of a trick, and particularly with the guidelines around do not drink when you're pregnant or breastfeeding. Women can think they're not getting any alcohol when in fact they are getting a small amount. The other thing I find is with young people, they're perhaps more likely to be drinking premixes, or the other thing that they're really across standard drinks. So they'll say, yeah, I have this particular drink, and on the side of it, it's a premix and it's got 1.6. And so really just checking in. The free poured drinks are a bit of a tricky one. Bottle of wine, just 7.5 to 8 standard drinks. Those kinds of things with the people that you're working with. The other thing is, in some particular groups, it can be hard for them to work out exactly how much they're drinking because they're drinking with mates. So it might be a slab of beer between 4 rather than them being aware that I'm drinking this much. So it really depends on the communities that you're working with. But bottom line, Liz, as you said, it's really important to really do a quantitative history of what they're actually drinking. That I'm a social drinker. It could mean it's half a glass. It could mean it's 10 schooners, or what do you call them, pots in Victoria. So so it's really important to just be curious and ask what people are doing.
Yeah, great. And in our research, we did work with some GPs who don't drink themselves for lots of different reasons, and they find pictures like this helpful for kind of helping to quantify with patients how much they're drinking as well. So thinking about asking about alcohol in general practice, I work in a practice now that pretty much we just work with people with substance dependence. So they're kind of there already kind of knowing that they've got some issues with their drug and alcohol use. But so I feel like I've got an easy job taking drug and alcohol histories because people have already kind of expected that as they walk in the door. And when I used to work in a sexual health clinic, that's like the easiest place to ask a sexual health history. But in community general practice, people come in undifferentiated, all kinds of problems, and it can be one of the trickiest places to ask about problems that are, sensitive and stigmatized. This is really nice work from Michael Tam, who, if you're on GPs Down Under, I think his nickname is the Prof. So his work looked at how patients feel comfortable to be asked about alcohol. And his work really showed that if you ask of it in the context of SNAP, so smoking, nutrition, alcohol, physical activity, people kind of understand that, it's part of their medical history. But people found it more acceptable to be asked about alcohol if they'd come in for something like diabetes, which is maybe like a whole body issue, but they found it a bit problematic if it was sort of asked out of the blue, but they'd come in for back pain. And so Michael's work really shows that context is really important, and explaining to patients why we're asking about alcohol can make it more comfortable for them. But, you know, sometimes asking about alcohol out of the blue, if the patient can't put the two problems together, can be problematic. Hester, did you want to add anything there, or Mark?
Yeah, so I mean, I work in both the specialist setting and the GP setting, and you're absolutely right, Liz, that it's something, you know, somebody comes in for a cold and suddenly you're asking them about their drinking, they go, what? Why are you asking me that? But it is really important to opportunistically ask. So, you know, really helping people to understand why you're asking, you know. So the sort of thing I would say is, you know, as your GP, I'm concerned for your general health and well-being. I know you've come in about the cold today, but I just wanted to do a bit of a check of your general health, and lifestyle things can actually impact health. Things like nutrition and exercise and stress and, you know, weight and alcohol and smoking and other drugs and gambling. All those things can you know, can cause issues. Is it okay if I ask you about them? And I've never had anybody say no. And so it sets up the reasons why I'm doing it, and then asks permission to do it. If somebody says no, and I have had a couple of people go, oh, Hester, look, can we do that next time because I've got to pick up the kids? Fair enough. But if people say no, then you know, it gives you some really interesting information around what's going on for them. And you might leave at that time. But the thing that we have that is so fantastic as GPs is we see people over time. So you can just keep a little mental note of that, put it in the notes, and just gently come back to it, because there might be really good reasons why they're concerned that you need to work through with them.
Great.
Yeah, I think as well, quite a common presentation is, Doc, I've come for a checkup. And that's the perfect time to, well, run through the SNAP, but look at that as well. But, you know, weight consultations are very important and common as well these days. And again, looking at alcohol under sometimes the mask of calories in, calories out, and oh, that's a lot of alcohol you're drinking. And I find particularly with some of the pre-mixed drinks, the amount of sugar people are having, let alone the alcohol, could be quite frightening, really. But yeah, no, I wouldn't have anything else to add.
Thanks, Mark. That's great. So I guess that moves now to the more meaty section of the talk. So the brief intervention. So a brief intervention just means when we ask someone about a problem and give personalised advice. In some research, they get really nitpicky and protocol driven about, you know, what an alcohol brief intervention looks like. And you have to ask this question and then this question and this question. But again, Michael Tam's work has really shown that personalised conversation in the context of a good relationship with a patient is the most effective thing. So don't ever be put off that, you know, you've got to ask exactly the right question in exactly the right order to get the brief intervention right, because general practice research really doesn't bear that out. It's about that personalised advice to the patient. Motivational interviewing, which is something that we toss around quite a lot in general practice, is a really another effective way of doing a brief intervention. And really that's about sort of rolling with resistance and getting the patient to sort of talk more about what they want to happen with their alcohol in this circumstance. And it's definitely not that sort of paternalistic approach and finger pointing and telling people what to do. That doesn't tend to work in terms of getting people to change behaviour. So it can happen within one consultation. And like Hester said, we have that real benefit of seeing people over time. So it might be just sort of little bits and pieces over time as you see someone. That can also be helpful. The relationship you have with the patient is really important. And when you kind of do ask your patients about alcohol, we know that it reduces how much risky drinking people do. It reduces their number of drinks over the week. But it's not enough for patients who have alcohol dependence. If someone has alcohol dependence and they really do need more intensive wraparound care, this is for someone that's probably drinking like a little bit more than those NH and MRC guidelines that we talked about at the beginning. But if you pick up someone that has alcohol dependence, then really they need that more intensive care. Mark, did you want to say anything about alcohol dependence in the community where in West Victoria there, and where people would go?
Well, I think the first thing to say maybe is that it is surprisingly common, and the average length of an alcohol dependence, as opposed to just increased use, is about 20 years. So you have a long window with people, and if you don't say anything, nobody else is. So you almost, as long as you don't offend someone, you can almost not say the wrong thing. There is a lot of help out there. There is a handout we're going to have that's available on the website attached to this talk, with lots of resources that people can phone themselves. And then the referral in the local region is all through the 1-800 numbers. So the whole of the Western Victoria BHN area is accessed through these numbers. And yeah, it's interesting. I was going to talk about this a bit later, but basically... Oh,
yeah, we will come back to that at the very end, Mark. Yeah, we'll...
But basically, yeah.
We'll put a little
used to be
for that.
very frightened of alcohol dependence and alcohol problems in patients, because I felt I knew nothing and I didn't know what to do. But actually running through these screens that you're going to show now shows it is actually quite easy, and you can just make people aware of what's risky and what the problems can be and how they can cut down. And it can be as simple as changing from a higher alcohol drink to a mid-strength beer or a low-strength beer or an alcohol-free gin. There's lots and lots of options now which are socially acceptable, which didn't used to be.
We have got a question, and Mark, I don't know if you know from what you bring up before, but do we know how many kilojoules in alcoholic drinks?
Well, what I do with my 20+ years of experience is just hop onto Google. And Google always tells me. So I'll type in how many calories in, Jim Beam and Coke.
Oh, yeah, great.
And I just do that. And then I say to people, and often you're showing people Jim Beam and Coke, and you say, for goodness sake, look at the sugar there, and, can you just have less and also have it with tonic water or a sugar-free Coke? So, yeah.
Thanks for that, Mark.
That's what I do.
The other thing is that people can look. I think there's a little bit of lovely marketing going on there with the low carb beers, that somehow they're healthier because they have less carbohydrates, so less kilojoules. They still have the same alcohol, so people can feel like they're being healthy because they're doing the low carb beer, but they still are getting the alcohol. So the kilojoules and the alcohol are two separate things. They're both important.
Thanks. And we'll come up to the next section now. We're really going to talk through some practical strategies that we might be able to offer patients. So again, this is a flow chart of a brief intervention for alcohol. And the idea of this flow chart is not that you need to memorize and know every bit and all that kind of thing, but it's meant to sort of pop out some different strategies and ideas you might use for approaching the conversation. And sometimes, so one patient, part of it might be okay, and for another patient, another bit might be okay. So first of all, we've gone through, can we ask about your alcohol? We didn't actually talk yet, Hester, about the audit C. I know that you use that one and find it useful. I find a lot, my alcohol histories really get warped by what my practice software points me towards, and they don't all use the audit C. Hester, what do you tend to use for your alcohol histories?
Yeah, look, I think you're really right, Liz, that what's in the software does make a difference, but the audit C is just a really simple way of remembering to ask how much, how often, and then the full audit, which is the WHO validated score, then goes into more detail. The one thing to remember with the WHO audit is that their levels are higher than the NHMRC Australian levels. So they talk about 6 standard drinks, whereas we're talking about 4. But it's still one of the things. It's really nice to have a validated score. You can say this is from the World Health Organization, and this, these are the questions that we're asking. We know that they're important, so it validates what you're asking again. So once again, it's just coming back to, what are you drinking, how much, how often, and then you can go into more details if you need to, around the risky activities or the things that are happening as a result of your drinking.
Great. And if we do the audit C, and we're working at, this is not again for people with alcohol dependence, that's another whole situation, but if people are drinking a little more than the NHMRC guidelines, that's when we can kind of use these alcohol brief intervention tools. So if someone is drinking a little bit more than the guidelines, they're happy to talk to you that day. The suggestion is, talking to, the less you drink, the lower your risk is from alcohol-related harm, is kind of a generally good thing to say. One initial strategy is then asking people if they want more information about alcohol. And one of the things we found, we went and talked to GP colleagues, is the real difference you find in people's understanding about harms from cigarette smoking versus alcohol. And a lot of GPs talked about, I've never met a patient that doesn't know that cigarette smoking is not good for them, but I'm often starting a conversation with people unpacking a lot of things about, alcohol is good for my heart, and if I drink this much, it will make me live longer, and all of these kind of myths really about the health benefits of alcohol. Mark, does that ring true for you with the smoking and alcohol and people's understanding of health harms?
Yes, I think so. I agree completely with you there. Yeah, absolutely.
I don't know how long ago that study was that came out that apparently red wine is good for your heart and makes you live longer. I haven't heard that myth as often lately, but it must have been 5 to 10 years ago. Do you think, Hester, that one came out?
It was a long time ago, and it did have some funding from the alcohol industry.
Did it?
Mm.
I don't know.
But look, it's the J curve, this idea that if you have less alcohol, if you have no alcohol, you're at risk. If you have a little bit of alcohol, it decreases your risk. But the reality with it was, who are the people that choose not to drink at all? Or at the time that study was done quite a few years ago, it's likely to be a group of people who actually are higher risk and are choosing not to drink. So, but the other thing, and I don't know where this came from, I should check it out before I come out with it. But, the bottom line is, if there is any benefit from that J curve of having a little bit of alcohol, you can get the same benefit from going for a 5-minute walk. So basically it's nothing.
I see. So that J curve, I haven't heard it around, my patients don't bring it up as much lately, but it definitely was very, very popular.
And it was red wine.
Red wine, yes, definitely red wine. I don't know why I'm surprised that the alcohol industry was involved in that. I really should learn after all these years. So again, in the package online that you'll be able to access, there are posters that you could put up in your waiting room or your consultation room to start people thinking about all the different ways that alcohol can affect the body, and it really is every system in the body. And then the other thing that a GP we spoke to in Melbourne was already using this sort of approach, was that they found that talking to patients about cancer risk and alcohol was really effective, because most patients had no idea that the alcohol causes, a linear increase in your cancer risk for many common cancers, and that showing them these kind of graphics really kind of brought it to the front of mind, particularly for people in their 40s and 50s, thinking about alcohol. And very interesting thinking about, say, breast cancer risk we're seeing quite a sharp increase in alcohol intake in women in their 40s and 50s, and breast cancer risk is a real concern there. So this is a nice way that a colleague was talking to patients in Melbourne. We've made a similar graphic available to you online if that might appeal to your patient cohort as well. So then another way you might steer the conversation, again, not all at the same consultation. This could happen 3 consultations later if you want to raise another kind of idea about alcohol, is thinking about what the person might like to change about their alcohol use, and things to think about of how they could go about that. And the reason we kind of came up with this little list with some graphics and things as well was there was a lot of alcohol information out there saying reduce your use, but not many things with practical steps about how people might go about that. And when you know your patient, you might go, well, they're not all going to fit every patient, but it might just give them some ideas. If they're not already going to the pub after work, well, obviously that one isn't applicable to them. But like Mark's talked about, switching to low alcoholic drinks, mixes in the drinks, changing up, a non-alcoholic drink in between your alcoholic drinks. These kind of really practical suggestions might be helpful. And it's also then helpful too, if you're not sure of many ideas yourself or your patient isn't sure either, some options to work through together. Mark, do you think any of those would work with your patient cohort? Or
I think they're all great. The interesting one, isn't it? Avoid drinking with heavy drinking friends. Because that applies across all fields of addiction, doesn't it? So avoiding people with unhealthy habits that you want to change.
Yeah,
is often very important.
And it's such a difficult one too, though, Mark. I've noticed a lot of patients sort of lose their friendship groups and their relationships because it just doesn't.
Yeah, that has been. I do have a couple of patients that have started drinking alcohol-free beer, and it is free beer, or the alcohol-free gin, because it allows them to sort of engage in the social aspect of it. Without having to have the alcohol at the same time. And both those things now are quite palatable, whereas alcohol-free wines really haven't got there yet, which is interesting. But the alcohol-free gin has, and the alcohol-free beers have. Yeah, the other thing is, again, applies to all addictions, isn't it, is distraction. So if people are thinking about having a drink, if they can just do something else for 5 to 10 minutes, often that feeling of, oh, I must need a drink, I have to have a drink now, will go away. And they can get up and do something else. So yeah, and having a cup of tea. I'm always telling people about herbal teas, and there's so many selections. You don't have to just be having coffee or tea or water. There's a huge variety now, from licorice to peppermint to whatever. Yeah.
And I'll just remind everyone, the alcohol dependence is, these are great tips. But brief interventions are really just for people who have bit of risky drinking, not alcohol dependence. And then I think the low alcohol, no alcohol options are really great for some people. And also I have seen people where it can be a trigger as well if they have a true dependence.
I think it can help for people with dependence as well. And I've certainly had people drinking very large amounts, and you say, okay, we're going to try and cut you down by 50%. So how about you change, one alcohol drink for one non-alcohol drink for one alcohol drink, and actually aim to reduce slowly, bit by bit, using a lot of these techniques, actually.
That's great.
Which works really well. So I find it's a fabulous slide, I think. Fabulous, actually.
Right. Hester, did you want to jump in there? I saw you come off mute.
Oh yeah, so I was just thinking, there's one of my patients, and I often tell this story, as a woman in her 50s whose husband had died. She came to me because she was having she was stressed. She was suffering stress because there were changes at work, and it came out over time that she was drinking a bottle of wine every night. And when she kind of realized she was doing this, she was pretty horrified. And then when we sat down and she started to think about what does it mean for you, went through the good things and the not so good things about that behavior. And suddenly it was like she had this light bulb moment, and she just went, I'm drinking because I'm lonely. And she was drinking a bottle a day, and she could have had a mild dependence, but as soon as she had that recognition, she just stopped and went, right, I've got to do things. I've got to change this pattern. So she joined a knitting circle. She got back in contact with friends, so she just realized what it was. Actually, the alcohol was a support and a symptom of something else. So she actually wasn't dependent at all. She just stopped it. So, really sitting down with people and helping them to work out what the alcohol means and the role that it has in their lives. These are brilliant ideas just around just shifting that habit a little bit. And certainly some people that are mild to moderate dependents may well, nobody wants to stop drinking completely, let's be clear. They want to cut down, and sometimes they can successfully do it, particularly if they've got mild dependence. But it's really good to have options. For people. But Liz, you're absolutely right. Some of my patients do not go near the alcohol-free beer, wine-looking products because it causes them to relapse. So it's not good for everyone. Yeah. And they're expensive. They've been priced to alcoholic drinks without any of the tariffs.
They're actually the same price at a bar.
A little bit cheaper.
I like $1. That's not,
Yeah. It's a bit of a con, really, the prices that
absolutely.
you're buying lolly water for alcoholic prices.
Yeah. So another kind of part of a conversation you might like to have with patients is thinking about coping strategies and preparing for potentially problematic situations. So common ones might be Christmas time or family celebrations, if alcohol is a really big part of what their family usually does. Also, work events can also be problematic for people, and that's sort of preempting those times where they might have a risky drinking episode and what they can do instead. And then thinking about this sometimes can be a bit of a strange question to ask people, and it does throw them sometimes, is asking, what do you like about drinking, and getting them to unpack that and what are the things that they like less, and thinking through. It's sort of that motivational interviewing strategy of getting people to think really through the pros and cons of what's going on for them at the moment. And then thinking about, if they do want to make these changes, how confident do they feel about making the changes? And then you can kind of unpack what could make you feel more confident or even less confident, and other times that they've made difficult changes in their life and how they've done that successfully, and really drawing on the strengths of things they've done before. Exit strategy, of course. So at any point, and this is true of any behavioural thing we talk about in general practice, that if they don't feel like talking about it, that you're happy to talk about it at another time if they wish. And it's quite interesting, in the research we did, that we talked to patients as well, and a lot of them didn't realise that GPs was someone you could talk to about alcohol, and that if they'd known that, then maybe they would have been more open to it. So it's quite interesting that patients don't necessarily see you as a GP, someone who wants to chat about alcohol. So it might be up to you to sort of make that first step. So we're going to jump into 3 cases now, which we'll talk through together. Again, if you have questions about anything we're talking about, or if you'd like to make a comment on the cases, please feel free to pop them in the chat or the Q&A box. So we're going to see Rodney first of all. He's 52. He's coming for his script for Candesartan. You've known him for 20 years, and Rodney's recently lost his job. And you're going through practice accreditation, which we are at work at the moment, and your practice manager said, everyone, fill in those alcohol boxes, for goodness sake. We're going to get in trouble. So poor old Rodney. How could we raise the issue with Rodney? Mark, I sometimes do the cheeky, I just need to fill in this box on my computer because my practice manager told me to. Rodney hasn't raised alcohol. What would you do, Mark?
I need to think about this for a minute. I'm sorry, I just lost the...
Have you got the slide there?
Yeah, no, I'm just trying to get it up. So I suppose I'd enter in, well, that's pretty awful for you. How do you feel about it? What do you think happened? And do we know why he's lost his job? No, we don't
know anything. That's it. That's the whole bit. I guess the options for raising the alcohol, would you... I guess the question, the option of raising the issue, I guess, is alcohol, because we're in an alcohol talk. Would you
I would be going, look, did you know that a common cause of hypertension and high blood pressure is alcohol? So we just
nice.
Let's have a quick look at how much you're drinking. Do you drink every day? Oh, right, okay. So you do drink it. Oh, what do you tend to drink? Do you tend to drink beer or wine, and how much do you have, and what time do you start, and do you have a drink? Did you used to have a drink after work, and how are you going now that you're not working? Do you start having a drink before 5 o'clock now? What happens? How are you filling your day at the moment?
Nice.
And I would approach it sort of like that, I think.
And I really like how you linked it to the blood pressure, especially thinking about Michael Tam's work and how people find that more kind of acceptable if it's the thing they've come in with and you're explaining why you asked. That's really nice. Hester,
Yeah.
what do you think about the cheeky, I'm just filling in the box for my practice manager?
Honestly, if it works for you, I think it's fine. I guess the issue is when they do say that they're drinking alcohol, then you've got to be prepared to have that conversation. The other things that you might raise with him, sometimes, you can say, look, you're 52 now, and sometimes as you get older, you can't handle your alcohol as much. So people will say, oh, yeah, I used to be able to drink a lot when I was younger, but can't so much now. So that can be linking it to age, also linking it to the job loss. And of course, we don't know any of the issues around it. He might have got a huge payout and be super happy. But, sometimes when people lose their job, that can be quite stressful. And sometimes when people are stressed, then they look for ways to manage that. And for some people, that can be substances, alcohol or other behaviors. So you can just kind of, as a question, is that happening for you? And allows them to, one of the really nice things about that way of questioning is it allows somebody who might feel a little bit ashamed about something that they're doing or a little bit, or not actually know that you want to know that, to be able to open up and say, yeah, actually I am.
Right. Sometimes we heard from GPs, well, it's not really any point asking people about their alcohol because no one tells the truth anyway. And I remember, at medical school, what do they say? At least double what everyone tells you they're drinking. These days, Hester, do you still go with that, or is?
No, I don't. I mean, I think there's really complex reasons why people might not say exactly what's going on. They may not know. They may not be keeping track. And once you've had a few drinks, it can be a bit hard to keep track. As we said before, it might be that they don't realise that that's something that you would tell a doctor. It might be that they actually feel really ashamed. And so, people sometimes do get it wrong, and sometimes people do underreport. And so you might say, so is that the usual amount? Are there times when you have more than that? And for me, it's around the way you do it with a kind of a curious, respectful approach that allows people to just let you know what's really happening.
Yep.
And for us in general practice, we're just so fortunate because our patients know us and they trust us. They come to us because they trust us. So we're perfect to have these conversations. I'm sorry, Mark, I interrupted you.
That's right. And it is interesting, isn't it? So sometimes people, you ask them how much they're drinking and then they tell you, and you're actually quite shocked, going, wow. And then you sort of go, oh, that seems quite a lot, actually. How do you feel about that? And they go, nothing wrong with it. I love it. And then you're in a different part of that whole cycle of addiction and where to approach it from. They're pre-contemplated. So, but it's interesting to open up that initial conversation, isn't it? And start saying, well, actually, that is quite a lot, and perhaps that is affecting your blood pressure, and gee, this will be having effects on your risk of other things. But anyway, it's fine. Let's have a chat about it when you want to, sort of thing. Yeah.
Right. And the other way is to overshoot. You say, oh, when you go out with your mates, how many do you have? 20, 30? And
yeah.
Either go, oh, yeah, or, oh, no, not that much. Yeah.
Yeah.
So Rodney is a less typical patient, I would say. But you raise the alcohol and he's really annoyed. How do you deal with that annoyance in your consultations? Hester, you said you've never no one's ever declined. But have you had? There's never been an annoyed patient, I'm sure.
I never, no annoyed patients in my whole life. No, absolutely. So sometimes people will get a bit annoyed with you. So I have one patient that every time he comes in, he goes, don't ask me about my drinking, Hester. So it's, all right, when you're ready, I'm here, mate. I'm here, I'm here every month or, every 2 months when you're ready. So it is, what's the annoyance about? And you just got to feel it. How well do you know Rodney? If you known him and his family for 20 years, maybe you sound exactly like his partner who's been, nagging him about his drinking. So it's just important to understand and just, you see, if it feels right to say, look, you seem a bit annoyed about me asking that. Can I understand what that's about? And you might go, no, just get out of my face, Hester. Okay, totally fine. I'm here when you need me. I am concerned about that level of drinking. It does have health risks. Come and see me when you're ready. Let's deal with the stuff that you've come for.
Yep, that's great. And Mark, do you ever have annoyed patients or no annoyed patients with you either?
No, never. Again, so yeah, look, I'd say if Rodney seemed really annoyed, I'd actually, I'm sorry for bringing that up. It is a important part of blood pressure. And I was just worried how you were going, you know, how are you going without your job and how's that going? And, you know, this is just part of the standard health review. So doesn't mean anything to me, and we can certainly move on if you want to, but let's, you know, if you ever want to talk to me about it, no worries.
Yeah. Yeah.
And again, a sort of open, you know, I do it with an apology and just say, look, it's part of a standard health review and it's part of it. So
Yeah.
we don't have to do it now at all or ever if you don't want to. Yeah.
Yep. I think I use a bit of apology too often when I come off wrong.
I'd be going, damn. So.
Yeah. So we'll move to case 2. So a change of pace. Penelope, she's 43. She's a long-term patient at your practice, you know her really well. She's otherwise no ongoing health issues, but she's coming specifically because she has noticed her alcohol drinking has gone up and she's seeking help. She has 2 housemates. She works full-time in an office environment. She's drinking a bottle of wine every weeknight and up to 2 bottles on the weekend. So is Penelope at risk for severe alcohol withdrawal? This is a question that we often worry about because it is really, really dangerous to go cold turkey from alcohol if you have alcohol dependence. Hester, do you want to take it first there?
Yeah, so she's drinking 8 standard drinks 4 nights a week, and maybe 14 to 16 standard drinks, maybe 2 or 3 times a week on the weekends. With that kind of level, I wouldn't be that worried about severe alcohol withdrawal. It's much more likely if you've got a much higher rate of alcohol intake. But I would be wanting to know, if you have a day off, Penelope, what happens? What do you notice? If you have 2 days off, what happens? What do you notice? And generally people that are drinking this amount, if they do have a day off, they will say, well, and she's working, so she's probably not having her first drink until after work, and she'll get that craving. The cravings will start. She may not sleep so well. She may be a bit irritable. And so what we would expect is, or she may not have any of that at all. But we'd be this one. I'd be looking at this. It'd be potentially a mild dependence. Potentially, there might be a little bit more happening there that we don't know about other drug use. That might make it a bit more complex. She's got no other chronic health issues. Her liver may well be fine. I'd like to do her liver function. I'd really like to know what's going on there. If it is abnormal, then it does give you another hook around this is actually affecting your liver. And also just looking at how is it affecting her sleep? How is it affecting her mood? How is it affecting her relationships with other people? So, it's unlikely. But if she has had a severe withdrawal in the past, if she's someone that's had seizures in the past or delirium in the past or has had to go into hospital because of withdrawals in the past, she is at increased risk.
And so what sort of level, Hester, do you start to think, oh, this is looking like?
The group of people that I see are the 4-litre cask wine. So the 40 standard drinks a day. I mean, if it's 20, I'd be looking for moderate. If it's higher than that, if it's a litre of vodka, or if it's your 40, so that'd be what? A litre of vodka would be, I've forgotten how to work that out, 4, 8, that'd be about 20, 30 standard drinks, something like that. So that kind of level, you are more at risk. But even with that level, sometimes people don't have a great deal of withdrawal. But certainly with that kind of level of alcohol in a GP setting, if I'm not in a position to support them and don't have easy access to an inpatient setting, and if there's been any history of severe withdrawals, I'd be getting in contact with my local specialist team to get some support around if the person was ready to do a withdrawal. If they don't want to do it, it's about keeping them engaged and potentially, as Mark said before, maybe looking at a little bit of a cut down. Maybe you could cut down, have a little bit less on the weekend, see how you go, and seeing them over time. I think the really important thing to remember is if somebody has an alcohol dependence or an alcohol use disorder, they have a chronic relapsing medical condition, just like diabetes, just like asthma. And so it needs long-term care. And withdrawal is just a little bit of that journey.
Yep. And for someone like this, thiamine, would you both?
Yeah, totally.
Yeah, it's often one we forget I need to often put a post-it note on my computer, thiamine, don't forget thiamine, to protect people's brains and nervous systems. I'll move to the next tricky one. So Valium and home detox. Our service, we kind of decide we don't really offer that very much because we often have people with polysubstance dependence and they have really difficult home situations, and it's not probably going to work if you look at the evidence. Hester, do you do home detox or what?
Yes, I do. In the general practice setting, it can be brilliant. The important thing about it is that it is a structured program, generally with daily or second daily pharmacy pickups, and very, very regular, if not daily, review by myself, by my nurse, by another practitioner. So if you're only there once a week, that can be a bit tricky. And you want someone who doesn't have the other complications of other drug use, who has a stable accommodation, good supports, but also has done a bit of pre-work around, I am ready to do this, I'm ready to make this shift. And you know, if you've got someone, and that's not uncommon, that group of people, that you can manage it in the general practice setting with the support of your pharmacy, your nurse, whatever you need, you know, depending on how often you're there, and follow up with them. And it's generally 5 to 7 days only. Different states have slightly different withdrawal protocols, so check what your state one is in Victoria, but it can be highly effective. And don't forget the relapse prevention medications, things like acamprosate or naltrexone. And this is a group of people who often do really well and can actually stop. The group that I tend to see in my specialist job are their disease is much more complex, and they need much more support than an outpatient detox.
Mark, is it something that's offered in your clinic setting?
Yes, it is. It's something I do. So the interesting thing about this patient is she's actually approaching us for help, which is fantastic. So it'd be really interesting to explore what's led her to this point where she's going, oh, I need some help. I would like to do something about it. What has changed such that she wants help? What's upsetting her about it? And those motivational questions that you had earlier in your slides, you know, what did you get from the drinking? Now, what is the reason that the benefits of your drinking are now not outweighing the downsides? What is it you want to do about it? And I'd say about this case, you know, 43-year-old lady, executive assistant, in most general practices, this person would be pure alcohol. It's very unlikely there's poly drug use going on. So I think you're dealing with a pure alcohol problem. And what we find in doing detox, and I'm sure you guys know, is that it does seem to be about 70% of the clients you see are alcohol. And a lot of them, it's just alcohol. It's not the other drugs as well. There is that sprinkling of other drugs. So this lady seems absolutely perfect for a home detox. And then my practice has been to sit down with them. Okay, when are we going to do this? You'll need some time off work. This could be really helpful. Okay, here's a script of diazepam. Let's work it out. You're gonna have it 3 times a day, and maybe, you know, you can look at the local protocols, or you can go, you know, 1 to 2, 3 times a day, and then you actually write out, okay, we're going to start on Friday night. How about when you get home from work, you have 1 on Friday when you come in the door, perhaps 1 or 2 tonight. Saturday, I'll write it out. Morning, lunch, evening, dinner time, maybe 1, 1, 1, 2, and just work out with the patient exactly what feels comfortable, and then see them frequently, even if it's a phone consult, how you're going. And if you can enlist somebody in the family to check on them, to be part of the plan, that's really fantastic. So this lady, you know, your 2 housemates, how close are they? Are they really good friends or not? You know, maybe you say to them, look, I'm actually going to get off the grog for a while, and my doc's going to give me these tablets to help. How about, you know, he's quite keen to get some help from you guys. What do you think? And, you know, approach it like that. But it sort of sounds very scary. And again, in early years, I would always refer off to do that. But actually, as Hester says, it works fantastically, and it's actually quite an easy thing to do when you're seeing someone regularly and got the checks. And you know, this level of alcohol is a lot for your average person, but actually in terms of severe withdrawal is not too bad at all. They are going to feel uncomfortable and have cravings and not feel great, but they're not going to be sick and need nursing care or anything else.
Yeah. I think in this situation, she's most likely to need the diazepam. And I think, Mark, you're talking about 5 milligrams diazepam. Yeah. Because otherwise she won't succeed. She'll become anxious, the craving will become too much. And so this is around helping her. So the pre-work, which is around, and yes, she's come in wanting help. So that's fantastic. I'm ready to do this. I've set things out so that I'm ready to do this. And then the diazepam, what I always say to people is you just want to be kind of chilled, not gaga and dribbling on the couch, but not hanging on by the skin of your teeth. It's about supporting you to make this important change. And then the work begins. The other thing I just wanted to check, you know, and I don't think this is the case for her, but are there children in the mix? Do we need to think about child safety? You know, what is happening at home? Is she on her own with kids? You know, those kinds of things. Just do consider the kids. And the other thing is driving. You know, so if she's drinking this amount every night, she may well be still intoxicated, still over the limit driving. So just need to, they're sensitive issues, but it is something just to keep in mind. And it can be a really great driver in terms of changing the behaviour as well.
Right. And we've talked a lot about options there, and we'll come back to Mark after we finish these slides for the local options as well. And then our last case is a real switch of pace. So Jeremy, who's 16, he comes to the appointment with his mum. Mum's really worried about him. He's always out on the weekend with his friends. He's going to school, but he hasn't been handing in any of his work. And he lives with mum and his older brother, who's age 23. So drug and alcohol for young teenagers. I think our image is sort of Jeremy with his hoodie over his head, sitting there beside his mum, looking at the ground and grunting. Hester, what's the magic here? What do we need to do?
Yeah, so who's the patient here? I mean, mum has dragged Jeremy in, and he may well be one of those kids that's going, nah, you know. But so, okay, so you say, all right, so first of all, mum, I just want to just hear what your concerns are, and then I'm going to ask you to go out of the room. Jeremy, if that's okay, I would usually do that because I want to have a conversation with you that is confidential. I just want to, you know, set those bounds of confidentiality. So, you know, and be really clear that I will not disclose this to your mum. The only time I will disclose it is if I'm really concerned that you're at really high risk of harm, you're putting someone else at high risk of harm, or somebody's putting you at high risk of harm, and at which point I will discuss it with you and we'll create a plan to make you safe. So, mum, what are your concerns? Beautiful, mum, going to ask you to go out of the room. And so then when you've got Jeremy on his own, he may be a kid that just goes, no, I don't want to know. The heads assessment can be a really useful tool, just starts off with the less sensitive issues and drills down. We don't know what's going on for Jeremy. And I look at this as a 16-year-old. It reminds me of my son when he was 16 going out with mates and not doing his homework. So it may well, in fact, be that this is just a kid of 16 doing what 16-year-olds do, but it may well be that there are some real risks there. So, you know, and the confidentiality is incredibly important, and starting to open up that conversation and really getting a sense of what's happening. And it may be that the only kind of hook that you have to talk to him is, what do we need to do to keep your mum off your back? You know, so he might be doing all kinds of stuff, but it may be tricky to understand that. So the only thing may be, what can we do to keep your mum off your back? The other thing is just being aware of that risk and talking about risk and how we can manage that. But understanding he's 16, so his idea of risk and judgment is going to be very different to an adult's.
Yeah, absolutely. Mark, I don't know if you cover it in the last slides about treatment options for adolescents in your region. Or is it all still through the same?
It's all through the same phone number. You know, if they're under 26, press button 1. If they're over 26, press button 2.
Okay.
Yeah. The other thing that's worth commenting, it is extraordinary, isn't it, when you see older people going through rehab and detox, And then you take a sort of detailed history and you go, what? You were drinking how much at 14? And, you know, it is interesting that some people have a sort of full-blown dependency by the time they're 18, 19 years old. And it's, yeah.
Yeah.
Sometimes.
Yeah. The other thing is also asking Jeremy about smoking or e-cigarette use, because nicotine use is a bit of a marker for other stuff going on. And I know in e-cigarettes or vapes are quite popular, but certainly looking at that nicotine use history as well, and yeah, once again finding out what's happening with the alcohol, and what are the risks there, trying to quantify that. But sometimes it can take a bit of time for a young person to start to open up.
I think there's more and more evidence now that even the vapes that are sold as no nicotine actually,
they've all got a nicotine in them,
really high nicotine. And Hester, maybe, so if Jeremy does have alcohol dependence at this young age, can we still use medications for adolescents?
Yeah, we certainly can. I mean, once again, as Mark was saying, we do see as a group of quite young people who develop dependency early. And, the earlier you get it, the more damaging this is to your brain. And so you do want to, intervene early and support Jeremy to do that differently. And young brains are at risk of withdrawal, complications. So, it depends once again on how severe the dependency is. Really good to get your youth services and your youth drug and alcohol services involved if there's adolescent dependence. Absolutely.
That's great.
I think in terms of Campril and now the naltrexone, they're not authorised for under the use of 18-year-olds.
Sorry, yes. I was thinking of the
the diazepam on the withdrawal and antidepressants and treatment for ADHD, etc., which all can be very helpful. It's interesting, isn't it, looking at the Campril and the naltrexone. So the effect for use in adults, I don't know what you guys' experience is, but it seems to have about a 15% overall effect, but once in a while it'll be fabulous.
Yes.
So it almost seems to be worth trying in every adult with an alcohol problem for relapse prevention and even reducing drinking, because you can drink on these medications and still be safe. But a lot of the time, a lot of people say, oh, I didn't do anything. But once in a while, it does a lot. Is that, that's what you'd agree with that? Yeah.
Absolutely. Absolutely. Yeah. So the thing that I'd always say to people when I'm prescribing naltrexone or acamprosate, and I tend to use naltrexone more just because it's once daily, whereas the acamprosate is generally 2 tablets 3 times a day, which is tough. Some people really like it, but it's to say, this will help. This will help. It'll help you feel a little bit more stable, but it'll only do about 40%. You've got to do the other 60. It's not magic. Yeah. And so it can't be on its own, but it's a really useful adjunct along with everything else that you're doing with that person, including helping them to manage their mental health, counselling, financial help, relationship counselling, all the other things that might be coming up for them.
So I'm just going to close out with some links to some of the resources we've seen today, and then I'm going to pass to Mark to go through the local options. So if you've liked some of the kind of images and the ideas that you've seen tonight, if you go to that QR code that's there on the screen, so if you just pop your camera on it and you press the link that comes up with the photo, I know people that were taking photos of the QR code, but it's not how it works. You got to press the link through your camera. It will take you to the website where you can find all the REACH resources, and they're freely available for you to download. We've got all of those patient resources we've looked at in multiple languages. So if you're in an area where people have a reading languages other than English, and I'm really happy if you have feedback or other questions, please get in touch. And I'll just pass now to Mark. And thank you to Hester and Mark. It's always lovely to chat about cases with colleagues. I really enjoyed that. So thank you, Mark. I think Jade's going to bring up your slides.
So just looking what happens in the West Vic PHN area. So this is an area that covers most of Western Victoria outside of Melbourne. And we're divided into basically 3 regions. So the Geelong region, the Great South Coast, and the Grampians Ballarat that goes all the way up to the Murray and the border. So in the Geelong region, if you're really Geelong centric, you phone that number there. So what happens is you get put through to the triage person. And as I said earlier, you get button 1 under 26, button 2 over 26. And then what happens is you or the client talks to the assessment person, and the person will do a brief assessment and fill in the form that's on the next page. If you change slides, Jade, that'd be great. So the Victorian AOD intake tool, it takes about 30 minutes to complete and gives a sort of overall picture of what's happening, a sort of a brief painting of what's happening, and also helps inform the person phoning what's likely to happen. And that really dictates what happens next. So unfortunately in Geelong, you will then be given an appointment for a much more in-depth assessment, depending if the person thinks that's what you need. And there's a 4 to 6 week wait in our region, which is a bit tricky. If it's a milder alcohol problem, then often the referral is much quicker, and it goes in the Geelong region, it goes out to one of 3 services. So that would be Barwon Health, let's see, and can't remember the name of the other one, but it all happens just for you. So the interesting thing that they said to me, or they do, is actually they prefer you to get the person to phone them up themselves. So they phone that 1-800 number and talk to the person, and then you can send in some background details to the sort of the fax number that you can get from those people. It seems a bit slightly different in the other areas. So if you're in the Ballarat region, you phone the Ballarat number, which again, if we go back a slide, please, Jade, is the Grampians Ballarat number. And then they will direct you to the local team that might be in the Wimmera. So they put you through to a different number. So it happens slightly differently there. Again, the Great South Coast, you phone the central number, which is based in Warrnambool, and they'll put you through to Horsham or whichever region you're phoning from. Again, they really like the client to phone up themselves because that helps with engagement. What they found is if the GP or the nurse practitioner sends in the referral, then often they're chasing the client, and by the time they get hold of them, either the client's not interested anymore. So it's almost a test of the person's enthusiasm to get help by them phoning up themselves. When I was trying myself to get in touch with them, you do have a bit of a wait. So they will, in the Geelong region, they'll take your number and phone you back. And when I spoke to the team, I was trying to get the nitty gritty. There were 7 other people in the queue after me waiting for help. So once you get the more in-depth assessment, which happens at different times, then they'll get a comprehensive assessment. So Jade, if you want to go ahead a couple of slides. So they get the AOD comprehensive assessment. That takes a lot longer and gives a real overall view of the person, from drugs used, amounts, the specifics, to the social aspects, to safety aspects. You know, the multi-agency risk assessment and management framework, which is MARAM, which is the new risk assessment for people at risk of violence. And then this document is used to really plan with the patient which service they're going to get sent to. Are they going to need detox and rehabilitation? Are they going to need just home detox, so a sort of nursing service from home that can visit daily and with the prescription from the GP work out a home detox plan? Or are they just going to need some counselling? And I think, as Hester was saying, you know, can be anything from financial advice to marital advice. So that's how that works. If we go to the next slide, please. So this is just looking at the more severe end of the spectrum. These are the rehabilitation services. So you've got Windana in Barwon, Maryknoll and Grampian. So they're the public rehabilitation. There's not a lot of withdrawal options in our area. So there's the Geelong withdrawal unit, which is in Caraya, and then you've got and that's linked to the Bendigo Bridge Rehab. There's actually Windana Rehab Facility in Barwon, and then you've got inpatients at the Western General Hospital and St Vincent's Hospital. So that's for people that have a really severe alcohol problem and need inpatient detox. And then you've got Odyssey House, which again, if you look, is outside our area. If people have private health insurance, if you like the next slide, so Veteran Affairs, private health insurance, or they want to self-fund, there are a number of community-based treatments from private outpatient treatments. So again, it's very Geelong-centric for Western Victoria. So you've got 3 private clinics within Geelong itself. If you Google it, there's a number of places through Melbourne, but, you know, under a handful. So, you know, including a couple of private hospitals, a couple of very nice looking, very expensive places in the Dandenongs. But it's really difficult. There's the Lighthouse project down in Warrnambool, where they're trying to get funding to build a community public rehab, a rehab facility, but so far the funding hasn't managed to get off the ground with the state government. So any questions about that? So I think the basic message is, for your area, phone the 1-800 number yourself, and that will give you a good grounding in what's available in your area. And then write a brief summary with a you know, past medical and other complicating factors, of which there may be not many at all, and then get the client to actually phone the 1-800 number themselves. I think we've included an information support and self-help. So if, like as in Geelong, the wait is quite long, there are other places which you can access, which are separate from the public service like this. And these are free services: family drug support, the self-help addiction resource centre, Shark. So there's a number of them, and there's a very helpful handout which lists them all. Just see there's a number of chats.
Thanks. I've just been watching the chat for you, Mark. There's someone called from Hamilton.
Yes.
Where would Hamilton patients be linked up to?
So Hamilton, you phone, hang on a minute, I think you go to Warrnambool. Let's have a look. Actually, I think Hamilton's on the border. And might be the Ballarat one.
Ballarat one. And the letter there that
I know Horsham is, so.
Yeah. The letter that you showed with the referral details, does it say on that letter where to send it?
It doesn't. So you'd have to phone the number and get the fax numbers.
Yes. Okay.
Send it to them. Yeah. Yeah. Sorry about that.
No. And Hester, would you like to share?
Yeah, so I just wanted to flag, and I should flag that I do some work with Clean Slate. So it's an online virtual alcohol withdrawal service. It is private, it's not Medicare billing, and it does cost around about $3,000, but it's a year worth of follow-up. And it's GPs and nurses, nurse practitioners. So it's really a nurse-led clinic. The nurses do the ongoing care, they have groups and they have counselling and they have follow-up with the nurses, and us as GPs, we do the pre-withdrawal assessment and the post-assessment. It's really useful for people who do have a little bit of disposable income, and one of the things with Clean Slate, super keen to actually engage with GPs. So, you know, if a person comes to Clean Slate, they will be asked to inform their GP and get a referral from their GP, and we will always send information back to the GP. So that's an option. That it's really great because it's virtual, so people can do it wherever they are around Australia. So that's one to think of, but it only if you've got the money to do so.
Thanks so much, Hester. Mark, did you
Yeah, I
want
was just refreshing my memory how Hamilton is, which is a bit pathetic. But yes, it's definitely the Warrnambool number. So phone that number and they will connect you through to the Hamilton.
Right. Helene, would you like to wrap up the webinar? I think we've come to the end of our information. Thanks again, Hester and Mark. That was great.
Yes, I would. Thank you, everybody, for attending this evening. That was absolutely fantastic. Great presentation and interaction from the three of you. And we had a good audience tonight. So please put your comments in your evaluations. And if you'd like any other meetings related to this topic, just put that on your evaluation, and I'm sure we could address those. So thank you again to all those that attended and to our presenters. Have a good evening. Goodbye.